Mariam Mobashera, Associate Professor, Department of Nephrology, NICDU, to update us for advancement in management of hyperphosphatemia, sucroferric oxyhydroxide.
Honorable Chairperson, respected panel of experts, and learned audience, Assalamu alaikum. Today my topic is Sucroferric Oxyhydroxide, which is an advancement in hyperphosphatemia management. So we all know that hyperphosphatemia occurs in chronic kidney disease, and according to KDOQI guidelines, serum phosphate level should be 4.5 milligram per deciliter or less than it. And according to KDIGO guideline, it should be 5.5 milligram per deciliter or less than it. So in case of chronic kidney disease, we all know that hyperphosphatemia occurs due to decreased renal tubular excretion. We all know that 90% of the serum sodium, 90% of the sodium which is absorbed from the gut, that is eliminated by kidney tubules. As GFR is lost in case of chronic kidney disease, then this phosphate cannot be excreted through the urine, and it remains in the blood. So it's the cause of hyperphosphatemia, where there's a development of secondary hyperparathyroidism, which causes dietary phosphate load to absorb into the serum, and ultimately it causes hyperphosphatemia in chronic kidney disease. So regarding clinical manifestations of the hyperphosphatemia, which occurs due to increased phosphate level, which then the product of calcium and phosphate, whenever it becomes raised, it causes production of the crystals, phosphate calcium crystals, which is deposited into the musculoskeletal system and in the soft tissues, arterioles, cerebrovascular system, and the skin, and on ocular manifestation then also occur. In case of musculoskeletal system, it is common to deposit this crystal into the joint spaces, which can cause the acute arthritis, inflammatory arthritis, and also muscle pain due to deposition in the soft tissues, and also it causes the friable bones. Whenever this crystal deposits into the cardiovascular system, it may cause in the arterioles or the large arteries, then it may cause maybe the hypertension or heart failure, vascular calcification, which may cause the arteriosclerosis and systolic hypertension, ultimately LVH. Whenever this occurs into the central nervous system, then it may cause delirium, coma, seizure, neuromuscular hyperexcitability, which may, we can find the positive Vostick sign and Trousseau's phenomenon, etc. This crystal can cause acute pruritus as well as calciphylaxis. Whenever it occurs into the ocular system, then it may cause band-shaped keratopathy, cataract, and conjunctivitis. So we have we faced challenges of current treatment. Here only we can see that in case of chronic kidney disease population, this is given by the 2019 from the DOPS study. This is the study from dialysis outcome and practice pattern study program. So they showed that only about 30% CKD population has the goal of phosphate level, but 43% of the patients, they have phosphate level more than 5.5 milligram per deciliter, according to KDOQI, and according to KDIGO, it was 28%. So around 70% has not reached the goal of phosphate. So what are the options do we have in our hand? Currently, we use in Bangladesh some iron-based preparations like ferric citrate and calcium-based binders. This is calcium carbonate and calcium acetate, and non-calcium-based binder, cevilamine acetate. But in the other countries of the world, they use, including these drugs, they also use iron-based binder, sucroferric oxyhydroxide, and also non-calcium-based binder, lanthanum carbonate. So in our country, this is common drugs we used for hyperphosphatemia. calcium carbonate is the 500 milligram tablet, which has 44% elemental calcium. So whenever also this calcium carbonate, its efficacy depends upon pH, and it has a potential risk of hypercalcemia. Calcium acetate, it has 25% elemental calcium, though, but it has also a potential risk of hypercalcemia, but it is less than calcium carbonate. And again, these two drugs, we have to prescribe these two drugs around 6 to 8 tablets to reach the phosphate goal in the hyperphosphatemic patients. Sevelamer carbonate, it is 800 milligram tablet. This tablet also has a pill burden, so we have to give the patient for a proper control of the phosphate into the serum, like 6 to 8 tablets. But it's a costly drug in our country. Now come to the ferric citrate, 1 gram tablet, among which, into which 210 milligram of ferric iron here present. So whenever we give these ferric citrate tablet, then it may cause the iron overload, and as this iron can be absorbed through the GIT. Now it is the newer molecule, which soon we can use it for hyperphosphatemia management, sucroferric oxyhydroxide. It is a 2500 milligram chewable tablet. One can give it through the meal 3 times daily. So 3 tabs should be sufficient. It has 500 milligram iron, but this iron could not be absorbed into the gut, as it forms an insoluble salt in the gut. So what is the mechanism of action of sucroferric oxyhydroxide? It binds with dietary phosphate in the GIT to produce an insoluble phosphate. This phosphate cannot be absorbed, and it is readily excreted through the feces. So as phosphate could not be absorbed into the blood from the gut by this phenomenon, it tends to lower the phosphate level in the blood. This study shows comparative analysis of the phosphate binding effects of sucroferric oxyhydroxide, ferric citrate, and lanthanum carbonate in CKD populations. They showed that the binding capacity of phosphate binding capacity of sucroferric oxyhydroxide is nearly 3 to 4 times more than sevelamer, ferric citrate, as well as calcium acetate in the CKD population. They also said that this ferric citrate had a stronger iron cumulative effect. This is another research article. This is 1-year historical cohort study of the phosphate binder sucroferric oxyhydroxide in patients on maintenance hemodialysis. Here the study population is hemodialytic population. Here they also showed that the sucroferric oxyhydroxide has the double effect regarding the efficacy of phosphate binding capacity from the sevelamer. So here, this study shows that here the study population is the peritoneal dialysis patient. Here they also, this is population, they use sucroferric oxyhydroxide for 1 year, and after 1 year, they showed that, this is the result here, that sevelamer causes 25% patient has reached the goal of phosphate, but the percentage become 52.4 in case of sucroferric oxyhydroxide. They reach the goal of phosphate, like double of the sevelamer. So we can say that sucroferric oxyhydroxide, for the sucroferric oxyhydroxide, it is double the percentage of the patients reached goal with half the pills. These findings also, I want to show you that from the above research articles, they showed that sucroferric oxyhydroxide monotherapy provide rapid and sustainable phosphorus reductions. Like after the 4th week, 4 weeks, the serum phosphate level become reduced to 1.5 milligram per deciliter, where after 12 weeks, it is reduced by 2.1 milligram per deciliter than the baseline, and after 52 weeks, it reduced 2.2 milligram per deciliter. Regarding adverse effect, sucroferric oxyhydroxide has little adverse effect, like discolored feces, diarrhea, nausea, vomiting, rash, etc. Here is the thing, that among 707 patients, after 1 year, they showed that only 42 patients had, to some extent, adverse effect at the end of first week. But at the end of 27 week, there was no patient who have any side effects. Sevelamer, we know that it's also a product insoluble phosphate into the gut, but with this, they binds with vitamin A, D, E, K, or folic acid. So with sevelamer, these vitamins could not be reabsorbed through the gut and the deficiency will occur. But in case of sucroferric oxyhydroxide, they doesn't bind with these vitamins, so these vitamins is okay with this sucroferric oxyhydroxide. Regarding diarrhea, ferric citrate shows 21% patient has diarrhea, and the percentage becomes 6 in case of sucroferric oxyhydroxide. Again, the administration. Administration is very much easy with this drug because this drug needs no water to take it. So one patient can take it either a break and crush form, or it is a chewable tablet. One can take it by chewing. Dosing. This drug has a low pill burden, so one could give this drug or prescribe this drug 3 times daily, 1 tablet with meal, and if required, then 1 tablet can add it with this 3. Usually, 3 to 4 tabs per day is required to reach the phosphate goal. Here is a comparative chart which shows the cost effectiveness. So ferric citrate, if ferric citrate needs 6 tablets daily, then it would cost 150 taka daily, when sevelamer would cost 496 taka daily, though it would we have to use 8 tablets daily. And sucroferric oxyhydroxide, we can use 3 tabs, which may cost 135 taka daily. So take-home message is, we have a phosphate goal according to KDOQI guidelines, which is less than or equal to 4.5 milligram per deciliter, or according to KDIGO guideline, less than 5.5 milligram per deciliter or equal to it. And we have available phosphate binders right now. We are using some iron-based one, calcium-based 2, and non-calcium-based 1 drug for hyperphosphatemia. But there is a recent advancement to us. Here is sucroferric oxyhydroxide. Inshallah, soon we can use it also. And it showed better phosphate goal achievement in CKD population, as well as hemodialysis and peritoneal dialysis patients also. And sucroferric oxyhydroxide showed maximum efficacy with minimum pills. Here is the product SKF is launching today. The DPHOS, they named it DPHOS. Thank you very much for patience hearing.